that with our provider partners. What we found when we're getting these results is that we have a huge problem with our supplemental data. And that's, in hypertension, as you know, is not something that comes through the EHR, all through the other ways to get the data in. So we're now working very hard to fix our supplemental data issues. For diabetes control, we're doing pretty well there. We're up in here, but you can see most of the health plans are, and that's a great testament to all the work that everyone's doing on getting better diabetes control. And this is the combination. This is blood pressure control in diabetics. There's National 90. You can see Sharp again has gone up here, getting the same kind of great results that Kaiser is. So what about here in beautiful West LA? Here's the Kaiser results, and you can see the 3 different years for the different locations. So the different locations for Kaiser down at the bottom, and there's the National 90 at 75% control, and they're all doing pretty well, and they're varying through the years, but not a lot. So that's a testament to being able to implement a system and enforce it and keep it going. And we're going to hear from Joel about that in a bit, about how they're able to do that. So what about the rest of us? We call this slide opportunities for improvement. Right? One group I do want to point out here, Axiom Medical Group, right here on the left. They were one of our first partners in the RightCare initiative work, and you can see that they've improved quite a bit, and we were very happy to see that as one of our provider partners in the RightCare initiative are making strides. So that was the good news I saw on this. You can see there are some opportunities for improvement here. Some folks are close to the national 90th, but others have a ways to go. And the message today is we have ways to help you get there. So what are our internal opportunities with Blue Shield? Get our supplemental data squared away, and that'll extrapolate to other ones. You know, beta blocker after MI, I just heard yesterday that's probably going to go away as a HEDIS metric, and possibly go away as an IHA metric, but there's some other of our members that want to keep that work, other employer groups, so we're going to keep working on enforcing beta blocker after MI. We're having best practices, community forums to share these best practices of RightCare, and then we're continuing to support our pharmacy efforts with both provider organizations and community ones as we go forward. The other thing we developed was this best practices self-assessment tool. It was brought together from the data from RightCare Initiative, from AHA, Measure Up, Pressure Down, Together to Go, Million Hearts Campaign, a whole bunch of other stuff. And we reviewed this with a Blue Shield clinician, goes through this with a provider organization. We highlight what's essential, like if you don't have a way to track your data, you're probably not going to be able to, can't measure it, can't fix it kind of thing. We have resources embedded in it, and by doing that, you can do your gap analysis and see what kind of action plan you want to do for doing that quality improvement work. And then we follow up quarterly. So this is just kind of a screenshot of what it is. There's 23 items for hypertension, 19 for diabetes, and a lot of them cross over. They're the same. There's some unique things for hypertension, 8 things for diabetes. It takes an hour to go through this or so with a group, and we make it a very complicated rating system. It's yes, no, or sort of. So either do it really, or you don't do it, or you kind of do some of it, and that's the sort of. And then based on what they get on where they score, they can see, here's our gaps, and then, okay, what are the 1 or 2 things we want to improve on this year? Because you don't want to do more than 1 or 2. You try to do 13 things, you're going to get nothing done.
And since nobody can read that, could you just read off a couple favorites?
Key things that you have to have leadership involved in making this a priority. One thing you have to have. If it's not a priority, it's not going to happen. Another thing is having a database to be able to track your results. If you don't have databases, you can't do it. But those are kind of some of the things that are in this. I do have this available afterwards if someone wants to actually get the self-evaluation tool. The key thing when we go through this with folks is being honest in your self-assessment. A lot of people end up putting yes, and then when we sit down and go through with them, it's really a sort of. And so when you do that, it's like, yeah, we're really not quite doing that exactly the way we thought we were. And that provides those opportunities for improvement. We find that many have efforts toward RightCare initiative goals at various levels. Again, the idea is to eliminate strokes and heart attacks by attacking the 3 multipliable risk factors of diabetes, hypertension, and lipid control. And a lot of folks are doing different things with diabetes and hypertension and lipid control, but trying to get it under a way you can organize it and think about it as a quality improvement project. Synergizes with a lot of other programs. And as stated before, hypertension control gets you near term, closer to where you want to go, and rhythm control has the biggest long-term effect. The self-evaluation tool helps you plan and prioritize your efforts. We can provide clinical assistance, quality experience, and pharmacy. We have a great pharmacy team that helps folks. We're cleaning up our data. Again, that supplemental data issue we found was huge, and it was great to find. Now we got to fix it, and then it helps with financial outcomes for our ECO partners for the quality bonus program. We're going to continue to scale the work. Again, we have 14 that are scheduled on for this year to take us up to 40 provider organizations. Starting the Bay Area, UBP will help in those efforts. We continue to refine the approach based on our experience. Every time we roll this best practices tool out with a group, we find little nuances about, didn't think about it that way, or there may be different ways to do that, and we refine the tool as we move on, continuous quality improvement. We want to get to the 90th percentile on right care initiative metrics, and the only way to get there is with our provider partners. Can't do it alone, and we want to eliminate those preventable strokes and heart attacks. Questions? Yes, ma'am.
Yeah, I mean, you bring up a great resource utilization of pharmacists, and we've had some presentations here in the past, thank you, using the clinical pharmacists to help in management of hypertension. There are barriers to that seem to be unusually out there. One is cost, one is, I think, as provider non-acceptance. Can you just address that a little bit about how can you overcome that barrier? Because it seems like a great tool to have in the basket.
Right. So the two questions were, one, how do you overcome the cost barriers, and then how do you overcome the provider resistance, basically, in a nutshell. So yes, pharmacists are not cheap. They are cheaper than doctors, though, right? And so if you're letting everyone work to the top of their license, it is more cost efficient if you're doing population health management to have a pharmacist do pharmacist things and a doctor do doctor things. And so when you are, and really, like everything, it depends whose dollar's at risk, right? Who holds the risk for it. So if you have a big enough population that's at risk that you're responsible for, the cost effectiveness of having someone at a lower license that costs less work on some things they can work on, and that's working at the top of their license, that does provide an ROI to you. And it takes a while for you to understand that and generate that. It took us and my old group about 3 years to figure that out. Once we figured that out, we went from a half FTE pharmacist to 2 FTEs, and we had 5 pharmacy techs. Because again, pharmacists are expensive. What's not as expensive? Pharmacy techs. And the pharmacy techs really help with the med adherence and doing those phone calls. Mrs. Jones, have you been taking your blood pressure medicine? What's your blood pressure today? Right? Oh, you're not taking it. What was the barrier? Why couldn't you get a prescription? Oh, the copay was $400. Mrs. Jones, are you sure you tried to pick up the right prescription? Because Prince is generic, right? So those kind of things. And that's what a pharmacy tech can do under the guidance of a pharmacist. Why in the world would I have a doctor doing that? Because that's the old model. As a primary care doctor, I want to call Mrs. Jones and find out she took her blood pressure meds? Not really. I got other things I got to do, right?
And it's kind of boring for doctors, right? So it helps them do something they're more interested in.
More interested in, but again, working on the top of my license. That's something a pharmacy tech can do. Pharmacy tech costs pennies compared to what I cost, right? It's just cost effectiveness. And when you think about it as a population health and approach it in a systematic way, it just makes sense to have people do that. And Kaiser figured this out decades ago, and they're very, very good at it, and the rest of us have to figure it out too. The second part about the provider recalcitrance is really, like most quality programs, have a clinical champion that's going to do this. 2 or 3 people that are willing to take that chance to do the pilot program and show the results. And once people see the results, and for something like this, I guarantee it's going to work. All of a sudden, your problem is everyone wants to do it, and you have a different problem where you only have some resources, and how do I scale it? So, do I have an effective intervention, and then how do I scale it? And that's really what it is. Yeah, no.
So Scott, on the right care triangle, at the top of it, it has patient activation. Describe best practices across those provider organizations around patient activation.
If I had that silver bullet, my whole shot, shoot it, but I don't. That is probably the hardest nut to crack in terms of patient activation. In San Diego, the reason it's called Be There now, it developed private funding and went off in private funding, and the part of the program that was research there is something called Be There, and they have great patient activation PR slides that they can use. We just haven't found how to apply it, because that costs money if you're gonna go out and advertise that stuff, and who you should best apply it to. But patient activation is probably the toughest and the last realm of figuring out how to do that very well. What the research that we had at San Diego showed that, and those of you who are providers in here have all had this patient, hey, you need to quit smoking. Doc, I gotta die of something. Okay, well, it's really sad to die of something stupid, okay, so find another way to die. And trying, when you say, I'm not, okay, that's fine, do you have kids, do you have a granddaughter, do you have a grandson? You wanna see them graduate from high school? Those kind of things. You start thinking about other things in their lives that are important, because people have already developed those self-delusional defense mechanisms of why they're not gonna comply. I'm fine eating my 6-pack of donuts every morning for breakfast. So it's really trying to figure out how to do that, and I think that is probably the last realm, and a lot of that goes into the social determinants of health, which we're just getting into now, and that's really the last field, I think, of expansion.
So when Scott just mentioned the Be There campaign, it was something that the physician medical directors and several of the RightCare leaders worked tirelessly on to develop motivational and some patient activists to come up with those concepts where you're saying, and actually Be There, that slogan came. Jack White, one of our early champions, came up with that phrase. He was a grateful patient who had survived a heart attack, and he said he survived it because he wanted to be there for Judy White. And so then what we did was sort of a social activation campaign, at least among the medical groups and the other delivery systems, the Navy included, the VA. So the doctors were starting to talk about coaching the patients in a patient activation way by talking with them and using those storyboards. One of them was from my family. Be there to make your daughter's 16th birthday cake. My mother died of a stroke when I was 15. So those emotional strings, believe it or not, I think it was very helpful for motivating the doctors to form a band of brothers. And I have to say, in San Diego, it became a band of brothers instead of a band of brothers and sisters, in part because one of our own, the wonderful Ms. Nora Fain, Dr. Nora Fain, had a stroke herself and is in long-term care now. So the urgency of these issues, we learn about them again and again as our extended RightCare family continues to experience these events. And so Dr. John Overtveit talked about extended RightCare family. He joins us from Sweden a few times a year. And thank you for being here. If we could get him the microphone.
Thanks, Patty. And can I just underline what you were saying? Is I was really impressed by that program in San Diego. Not least because I think it created the environment within which other things could grow, and multiple things like that really make the difference. But my quick question is to follow up on what you were saying about the social influences aspects of this. Two quick questions to sort of dig into this a bit would be, first of all, what sort of percentage of your population are Medicare or come from low income? I mean, well, in my ignorance, I don't know about that. The second aspect is, the big challenge is, are there effective interventions or cost-effective interventions that could be used? And I'm interested in your thoughts about that. And also related to that would be what sort of turnover there are in your population as well.
Great. So you're asking two very good questions. One is, what about the low-income population? In California, that's called Medi-Cal. It's part of the federal Medicaid program. And when we acquired Promise Healthcare, that's why we acquired them. They were called Care First. They're in San Diego and LA and a couple other counties. California is very interesting state in the way that its Medicaid population is distributed amongst health plans. And that's all coming, reopened for bid next year, 2020. So our population expanded rapidly in 2015, because before that we had no Medicaid. And then suddenly we had a couple 100,000 lives in that. And so we're very interested in that. And part of the spin-off of San Diego RightCare is a new initiative called the San Diego Accountable Community for Health. And the second meeting for that is going to be next Tuesday evening, or Tuesday afternoon, from 3 to 5 down in San Diego. And we're absolutely looking at ways to address that. There are a number of health plans that are sitting at the table for that, including United, HealthNet, Anthem, and ourselves. And there'll be some other ones there probably too, and the providers involved. But absolutely, there's so much you can do on the provider side, and that's what we've done so far with RightCare. But the social determinants, you know, that old saying, zip code is more important than your genetic code in your long-term outcomes. So how do we approach that, especially now that we're in that population, and that's an interest in improving the health of those communities. So that is the next frontier, and our preliminary meeting actually had a couple of different ideas on how to work on that. We'll see where that goes, but actively engaged in that. And I appreciate the other partners that are there with us to try to work on that.
So I think because you need to get on the road, do you have time for one more question?
Sure.
And do we have one from Memorial here?
I was just gonna ask, your secret sauce slide about the thiazide and the calcium channel blocker, is the reason why BMI reduction and tobacco cessation sort of not part of the secret formula just because of patient compliance and how difficult that is, or do you have any data on any groups that worked on either of those?
So when you look at the weight loss literature, what is the 1-year success rate of people losing weight on all the programs, the best practices? What's the best one that someone has where they can actually sustain weight loss for a year? You know what the number is? Is it more than 10% or less than 10%? Less. Is it less than 5%? Yes. Is it less than 2%? It's right around there. So if I'm going to go on something, I'm trying to get on something that I'm most effective at. Smoking cessation should be part of anything from day one. There is no safe smoking level. You only have to have a pack a day. If you start, the deeper you dig into genetics and what it can do to your DNA, the more you want to stay away from ever touching tobacco smoke. But there are many other programs working on that. We chose to focus on those 3 modifiable risk factors. The other one that we have dabbled in but really haven't nailed, and Bob Salas is a great, from Kaiser is a great ambassador for that, is the activity thing. Exercise as medicine is probably as effective as hypertension control in terms of reducing adverse cardiac events. So that is part of the whole social determinants, and that's part of making a safe environment for especially these high-risk families and neighborhoods they live in. They can't walk outside, so how do we create those safe zones so they can get some exercise in right where they live? And so that's something we think will fall in the social determinants part more so than in the medical part.
Yes, Oliver Brooks. I think you can take one more question, and this is the last question. Oliver Brooks from Watts Healthcare.
How do you plan to sustain where you are?
So that's a great question, right? So you find the problem, you fix it, and then you have to scale it and sustain it. And that's the hard part. What we've done internally at Blue Shield is we've made this our quality objective. It is in our long-term incentive plan for our executives. It's spelled out as one of our major 3 quality goals as an organization. So it's embedded in our plan for at least the next 3 years. That's what our long-term incentive plan is, a 3-year rollover thing. And so as you make it part of that quality program, then it's, because like many organizations, we're siloed also, right? So we have the Medicare quality program, we have commercial, we have Medicaid, Medi-Cal, how we do that there, the PPO, the whole thing there, and we have the OPA site we're working on. So the key is to have that hypertension control as part across all those, and then say, RightCare is a tool to go out and work on this. And we can come in and help you as a provider organization. We have a framework to help you with this best practices, self-assessment, and help get your providers up to speed on the best practices currently for hypertension control and diabetes control. And then you all know the lipid control just came out in November, in the ACC, KHA new guidelines came out. And we're using that as part of what we're doing also.
And
So
we will definitely be bringing those guidelines to this group. There's so much late breaking news.
yeah, so the real issue is how do you make it a program of record? That's what we called it in the Navy. How do you institutionalize it and make it part of it? So we've gotten a whole way to our CEO and our board of directors, and this, yep, hypertension control is one of our long-term quality standards. All right, great, let's go get it. And so that's how you have to get it as part of it. If you don't make it a program of record, it becomes Scott's special project and it'll fall apart. So,
And gotta get you on the
yep,
road.
all right, thank you all.
Safe travel.
Thank you, Scott, that was great. And yes, get on the road so you can get to that important meeting, so you can keep up the good work. It's my pleasure to introduce our next speaker, Dr. Joel Handler. And you can read his very impressive bio and the information you have there. Joel and I were both at Kaiser in the last century, right? But Joel was very famous at Kaiser. When I saw his name for the speaker this meeting, I thought, wow, I remember Joel, and I was not really associated with you in any way. But Joel's been the editor of the Journal of Clinical Hypertension. He was a hypertension enthusiast at Kaiser, started guidelines in the clinical practice program back then, contributor to the JNC 6 and 8. And again, I don't want to shortchange your bio here, but in the interest of time, I'd love to hear you come up and give us some pearls of wisdom that we can improve our control of hypertension.
Okay, thank you very much for that introduction, Carol. I remember my meeting Carol and sparks were flying in her laboratory. But this is a talk about hypertension control success in Kaiser Permanente. So I'm going to be reinforcing a lot of what you just heard from Scott. But I think the reinforcement is important because these are principles that have been established across large populations, across many different types of healthcare delivery, and so I think that establishes their credibility. So the objectives here are to review the key elements of a successful approach to hypertension control performance, construct a simple hypertension treatment algorithm, which Scott mentioned, and I'll go over in a little detail, define the advantages of population care in an integrated healthcare delivery system, and using equitable care to close the racial performance gap. So Kaiser Permanente nationally is more than 10 million members now. That's about 1 million larger than VA, 18,000 physicians, 38 hospitals, and it crosses, there are 7 regions that cross 8 time zones. We're in the Mid-Atlantic states, Georgia, Colorado, Washington, Oregon, and Northern and Southern California, and also Hawaii. So we have our national meetings, we're California-centric, and we have to recognize our timetables. Southern California, Permanente is the largest of the groups, and we have about 4.5 million members now, and 15 hospitals. So we're taking care of a lot of patients. There are HEDIS comparisons, top 10 performances that go back, and usually it's a year and a half delay before we get top 10 statistics. But you can see the performance is consistent from year to year to year. Going back 5 or 6 years, you can see that 7 out of the top 10 healthcare plans here are Kaiser health plans. And so that's all of the Kaiser health plans. We have 7 of them nationally. And the same is true for the commercial population. So what we have is a system that works across 8 time zones and 10 million people. So why keep talking about hypertension? It's quantitatively the most important risk factor for premature cardiovascular disease, more common than smoking, dyslipidemia, diabetes, as we know. It accounts for more than 50% of all strokes, almost 50% of all ischemic heart disease globally, and certainly increases the risk for chronic kidney disease, heart failure, atrial fibrillation, and peripheral vascular disease. So treatment works. We know that from the large-scale randomized controlled trials. We see a 50% reduction in heart failure, which is very sensitive to blood pressure control, 30 to 40% reduction in stroke, 20 to 25% reduction in MI. So we know that it works. How do we implement what we learned from these clinical trials? So you can see that it wasn't, as Scott pointed out too, many years ago, all the healthcare plans were at very low levels of control. In 2004, we were just above 50%. But you can see over the succeeding 5 or 6 years, there was a tremendous acceleration in blood pressure controls as we learned from implementation and best practice sharing and all this kind of stuff. It's a very rapid learning process that was disseminated. So part of the problem too was that we weren't identifying, our control rate was definitely overestimated because there's a large population with blood pressure, with hypertension that we weren't even identifying back then. In 2006, in Southern California, we got electronic health record, EPIC. So you can see that the change was occurring before the electronic health record came into play, but certainly helped augment the progress of success. Now, our health plans control rates are close to 90% most recently, and we continue to learn and sustain. Concomitant with the increase in blood pressure control and also free-flowing statins, thanks to Ron Scott and our hyperlipidemia teams and so forth, there's been a tremendous decrease in rates of acute myocardial infarction over the last decade. And you can see in the higher age group, the decrease has been almost 50% in MIs. Strokes have also decreased.
Can you go back to that slide? Let's really spend some time on those actual endpoints.
So you can see that for men and women that MI is certainly more common in the older age group. And that's where we're going to see the biggest, largest decrease. For younger age groups, we're going to see less of a decline, but nonetheless a significant decline because the numbers are higher. And in women too. Steve Sidney has done research with ethnicities and race, and what we're finding is the most stubborn population to reduce stroke is our African American population. And I'll address some time later to that very specific topic.
Thank you. It's beautiful to see the rates coming down, and it'd be very interesting to know what you think the primary